My name is Dr. Rahman. I'm one of the sort of consultants doing metabolic medicine, and I sort of do the metabolic bone disorders clinic. I'm also sort of involved with micronutrient deficiencies in the trust. So I see patients with bariatric surgery, and I was also sort of part of the TPN team. And I think over the years, like sort of dietitians have been sort of discussing about micronutrient replacement in sort of ITU patients. And we've had lots of conversation regarding vitamin D replacement because a lot of sort of things have been written about how vitamin D may be helpful. And this kind of led Zoe to sort of suggest that why don't you come and sort of do a talk on sort of vitamin D. So this is more to sort of just review the literature surrounding vitamin D in sort of critical illness patients actually. So the way I've done the talk is we'll just talk about vitamin D in general first, just to give you a kind of an overview and sort of just remind you of things which you already know. And that gives us a background to discuss, what are the kind of studies which have been happening in ITU sort of a setting patients actually. So yeah, so the main sort of organs involved with vitamin D is your skin, your liver, and your kidneys, and then your parathyroid. So those are the organs which are sort of mainly involved in your vitamin D pathway. So you need a certain wavelength of ultraviolet B to sort of make vitamin D in the skin. So you start from sort of cholesterol and then go all the way down to sort of making vitamin D. So vitamin D is like any other sort of steroid hormone. In fact, it's sort of more similar to a hormone in that sense. And from the skin, the vitamin D, it goes to the liver, and you get your first sort of hydroxylation. So that's called 25 hydroxylation. So vitamin D already has a hydroxylated group, and then your first hydroxylation gives it the second sort of OH group actually, and then from what you call as the liver, it goes to your kidney, and then you get a further hydroxylation. So you get the active form of vitamin D, which is called 125 hydroxylated vitamin D, and that is the one which has the sort of main sort of actions on the vitamin D receptors. To have your one hydroxylation in the kidneys, you need your kidneys to be working. So patients who have got, for example, CKD, they after a certain point would benefit from having active vitamin D. You also need a parathyroid hormone to do your one hydroxylation. So the only sort of two main group of patients who will need chronically, active vitamin D treatment are CKD patients and hypoparathyroid patients. Active vitamin D is very, very effective, and in fact, very easily can cause hypercalcemia. So outside of the setting of advanced CKD and hypoparathyroid patients, we don't generally use sort of active vitamin D. And then we'll just talk about some terminologies regarding vitamin D. So does anyone know, I don't know whether we can have a discussion here, but what is cholecalciferol and what is ergocalciferol, and what's the difference between them? People can type in the chat boxes if they are sort of joining us remotely. So your cholecalciferol is vitamin D3. So that's the thing which mammals, when the skin is irradiated by UVB, form actually. Ergocalciferol is vitamin D2. So that's not the natural form of vitamin D in humans or mammals for that matter. So ergocalciferol is what you get from mushrooms actually. So that's the like a vegetarian sort of source of vitamin D. So certain mushrooms, when they are UVB irradiated from ergosterol, they will make ergocalciferol. And vitamin D2 and vitamin D3 are equally effective. In the past, it was easier to make vitamin D2 supplements. So the supplements we had, say 20 years ago, they were all vitamin D2 supplements. But these days, I mean, most of the oral supplements are vitamin D3, which is a natural form that mammals have. Although the IM injection, which is sort of around, is still vitamin D2. They are equally effective at the level of the receptors. There's some difference in their sort of pharmacokinetics. So there is some suggestion that you need more D2 intake to get the same amount of vitamin D levels actually. So your cholecalciferol is D3, ergocalciferol is D2. When they say calciferol, when you don't qualify it it could be D2 or D3 actually. And then when you say calcidiol, that is your 25 hydroxylated vitamin D. So as I said, vitamin D already has a hydroxyl group. So when you attach another one, you get two OH groups. So that's called calcidiol. And calcidiol is the best way of assessing your vitamin D storage. That is your 25 hydroxylated vitamin D. So when we talk about somebody having a vitamin D test, what we are checking is calcidiol or 25 hydroxylated vitamin D. Then there is calcitriol, which is your 125 hydroxylated vitamin D. So you got three OH groups. This is your active vitamin D. This is also available as a tablet, which we sometimes use in, as I said, advanced CKD patients and in hypoparathyroid patients. There's another preparation called alpha calcidol. So alpha calcidol is slightly interesting because this is one hydroxylated vitamin D without your 25 hydroxylation, which happens in liver actually. And then, when you take the alpha calcidol, you get your 25 hydroxylation done in the liver, and then you end up with 125 hydroxylated vitamin D. So in terms of action, it works like an what you call as active vitamin D. So calcitriol and alpha calcidol, they are basically your like active vitamin D, and they can, I mean, if given inappropriately, cause hypercalcemia in sort of any patient actually. So it's good to know vitamin D terminologies. And then this is something I still get surprised a lot of people are not aware of. So the sunlight which forms vitamin D in the UK is only present during spring and summer months. So if you go outside, you will not form any sort of vitamin D. So this is just looking at the UVB, which forms the vitamin D. So if you look at, so second is Edinburgh, third is London. So like once it's October, there's hardly any UVB available actually. So yeah, so all your sunlight that you need, you should get in your spring and summer months. So if you're not doing any outdoor activities during spring and summer months, you will struggle to have good levels to last you during the winter months. And then the sunscreen sort of blocks vitamin D. So anything which is SPF 8 or above blocks vitamin D. And again, with sunlight exposure, it's a balance you need to have because having too much sunlight exposure can obviously cause skin cancer as well. So there's no sort of perfect rule for that. So usually what we advise is between spring and summer months for patients who have got, for example, osteomalacia, severe vitamin D deficiency, to expose their arms and faces for about between 5 to 30 minutes, depending on how light their skin is without the sunscreen. And that would give you enough, help you build up enough stores actually. So usually for Asian patients, we say about half an hour of sunlight to your arms and faces during sort of spring and summer months. But obviously, if you're much lighter skin, you don't want the skin to burn because the other side of that is you can get skin cancer. Uh, so the Royal Osteoporosis Society, it sort of defines uh, levels less than 25 as deficient. So that's the definition which we use in UK actually, and over 50 is considered sufficient actually. And between 25 to 50 is where you would, if you got a patient with, for example, osteoporosis or some other sort of, osteomalacia. So there you may want to achieve, or CKD patients. So there you may want to achieve higher sort of, vitamin D levels. If you look at American guidance, they suggest, or at least the older guidance suggested, 75 nanomoles per liter to be adequate, and below 75 nanomoles per liter to be sort of deficient. And usually, if we sort of want to correct vitamin D, so if somebody is symptomatic, so their alk phos is high or calciums are dropping, or they've got like, osteomalacia, weakness, aches, or if we were going to start them on, osteoporosis medications, for example, and you want a rapid correction on vitamin D, what we do is we give them about 300,000 IU over sort of 6 to 10 weeks. So something like 40,000 a week for 7 weeks, that kind of regime to build up this, stores sort of slowly up. If there's no what you call as urgency to correct vitamin D, then just simply giving 800 to 2,000 units over a long period of time will sort of correct it actually. And so this is I'm talking this because this becomes relevant when we talk about how this comes into play with patients with critical illness. And so the RDA for a sort of like an adult person is about 600 IU of vitamin D, which is about 15 micrograms. And the same is required during pregnancy and lactation as well. And then the tolerable upper intake level. So this is defined as the amount you can have without having any sort of serious concerns. So that's described as about 4,000 IU. So it's quite difficult to become toxic with vitamin D, but it does happen sometimes if you start taking doses which are 10,000 units or over, and we do come across that every 2-3 years that somebody has become toxic on vitamin D. And usually to have vitamin D toxicity, you need levels over 375 or 350 nanomoles per liter. So that's quite difficult to achieve unless you're taking very, very high doses. But up to 4,000 is considered quite safe. And usually if patients, for example, who have got sort of bowel issues or celiac disease or due to whatever reason, they need higher doses than 4,000, then we will monitor their sort of vitamin D levels just to make sure that they're not going up very high. And so, yeah, I mean, in the UK, the recommendation is that if you're Asian, for example, you should be taking vitamin D 400 units all year round, and that will ensure your levels stay, above 25, which is the lowest threshold you need to have. And in fact, for everyone during autumn and winter months, a lot of people are not aware of it. The recommendation is we should all be taking at the moment 400 units of vitamin D at least a day. And I mean, usually to achieve levels around 50, you'll need about 1,000 to 2,000, depending on your sort of body weight. But certainly, you should be taking at least 400 units of vitamin D. Now, this is slightly digressing a bit, but like if you're looking at any calcium problems, usually there aren't many things you need to work out. So if you've done a UNE's bone profile, magnesium, and then vitamin D and PTH, that will almost in 99% of patients tell you what the diagnosis is. And very rarely you may want to look at sort of urine calcium. So urine electrolyte is something which a lot of physicians sort of forget because that gives you a lot of value, especially if you're looking at some electrolyte disturbance, which you cannot sort of very sort of obviously explain actually. So usually, when you're contrasting parathyroid problems and vitamin D problems, you have to look at the calcium and phosphate. And usually, as a rule of thumb, if calcium and phosphate are traveling in the same direction, then in a patient with normal renal functions, then it's a vitamin D problem. So if you've got vitamin D sort of deficiency, you will expect low calcium and low phosphate. While if you've got vitamin D toxicity, you will expect high calcium and high phosphate, although very rarely in some patients you can get low phosphate, which has a very good explanation. But yes, usually if calcium and phosphate, they are traveling in the same direction, you're looking at a vitamin D problem, while in parathyroid problem, they would often travel in opposite directions. Um, so now the thing with vitamin D is, so vitamin D receptor, it sort of controls over 100 genes actually. And a lot of research has been done over the last sort of 10 to 15 years, and they've been finding newer and newer sort of pathways which are kind of modulated by vitamin D. And if you look at the amount of publications, so like since sort of 2000, there has been an exponential rise in the publications you've been having regarding vitamin D, because as all these genes have been identified, people have done lots and lots of association studies. So there are lots of studies around which says if your vitamin D levels are low, you're at risk of diabetes. If your vitamin D levels are low, you are likely to be obese. If your vitamin D levels are low, you can get breast cancer. So there are lots and lots of studies around showing association with low levels of sort of vitamin D. But what we don't have is whether treating that really helps, and is that actually related, or is it just a sort of a finding? Um, Now I've got some interesting. So I'm more well versed, obviously, with musculoskeletal literature rather than ITU literature. So this is a interesting study. This has been repeated twice in quite in a similar population. So you would think that vitamin D is good for your bone health. So what they did was these are patients in nursing homes, and they were giving them 500,000 like bolus vitamin D levels. And idea was that giving such high doses will maintain the vitamin D levels, and they will have less falls and fractures. But it has been shown consistently in 2, 3 studies now that in fact, if you give such boluses rather than giving a slow trickle every day, you in fact get more falls and in fact more fractures as well. So very high doses of vitamin D are being given unnecessarily when there's no like need, like patients do not have raised alk phos, they do not have low calcium. There's no need to give big bolus doses actually. There's a similar sort of meta-analysis looking at respiratory tract infections, and again, vitamin D has been shown to be effective in patients with RTI. But then, if you look at the last line, it's only effective in patients who were very vitamin D deficient. So people who are already okay, you don't need to really correct it. And in fact, patients who were getting boluses of vitamin D, they did not get the benefit in terms of improvement in their risk of having chest infection. And this is a very recent study from 2019, so University of Calgary in Canada. And so again, because of all this vitamin D associations, they did a study in which your 400 IU used to be the older recommended daily allowance. So now it's obviously 600 units for adults, and for elderly population, it's about 800 units. So what they did was they gave patients like your regular 400 IU per day, and then there were two groups, and they were giving 4,000 IU per day and 10,000 IU per day for 3 years. And again, the idea was that maybe at a higher level, you'll get more sort of bone strength and bone densities. But both the groups, the 4,001 and the 10,001, they had low radial bone densities. And in fact, in the 10,000 group, even the tibial bone density was lower actually. So again, the idea is to just have your regular amounts of vitamin D. There's no need to give very high levels or maintain sort of very high levels. Uh, I mean, if you look, the original sort of pictures I had shown you, it had a reference range that was an old reference range from 2007, and it was suggesting reference range between 50 to 250 nanomoles per liter. We've kind of, because of all of these publications, we've sort of got away from that. So yeah, I mean, vitamin D. Obviously, if you're severely deficient, then yes, you need to correct the vitamin D levels. And I mean, the best way is that if there's no urgency to give small amounts regularly, that's the best way to correct sort of vitamin D. There's a very big trial done in cancer patients. So this was 25,000 people actually, and they were looking at rates of breast, prostate, and colorectal cancer, and there was no benefit at all in giving vitamin D. In fact, in certain studies, they found giving too much vitamin D may be actually harmful. So in patients with pancreatic cancer who achieve levels of 100 nanomoles per liter, they had actually increased risk of pancreatic cancer. And similarly, in breast cancer, the women who were already sort of sufficient vitamin D, plus you were giving vitamin D on top, I mean, you wouldn't get new breast cancer, but if you did get breast cancer, it was more likely to be invasive. So vitamin D is not all good as people were hoping. Multiple sclerosis is an interesting one. So there's lack of evidence because there aren't any big studies, but there's no suggestion that it is beneficial. But certainly, if you run low levels, you should correct the levels. And the thing with multiple sclerosis is the highest prevalence is in places where there is no vitamin D supplementation in your food and what you call as and in northern latitudes actually. I mean, if I remember correctly, I think Scotland has the highest prevalence of multiple sclerosis. And again, other things like cardiovascular disease, depression, weight loss, COVID, it became quite popular. Government was dishing out vitamin D to elderly people, but quite sensible doses. But then I had patients who were taking like 10,000 IU every day and achieving levels of 150, 200 nanomoles per liter. And I had to tell them, oh, you need to sort of come down. That's very high. We just need about 50 for most sort of bodily functions, really. So again, there's lack of evidence throughout this. So yeah, I mean, so vitamin D before 2010 was kind of ignored. In fact, I remember I joined as a registrar in Leicester in 2009, and the consultant we used to have. So he used to get vitamin D supplements from Canada because in fact, in UK, we did not have vitamin D supplements outside of what we used to get for osteoporosis patients, which were combined with calcium. So if you wanted to get a pure vitamin D, That used to be a struggle. But then obviously with this boom of literature, a lot of health companies have got on the bandwagon and producing lots of vitamin D preparations. You can get 50,000 IU without prescription over the counter now. So in fact, when the Calgary study was published, there was an interesting editorial, again saying that vitamin D. Obviously, if you're deficient and you've got symptoms and biomarkers, then yes, you correct the vitamin D. But otherwise, it's not really sort of useful, and people should get away from just giving vitamin D for any associations that has been sort of published before. Now we'll come to vitamin D in, again, as I said, what we want is small amounts every day rather than sort of big doses or overcorrection. And if you have a good diet, all you need, if you're in the UK, is just 400 units, maybe 1,000 during winter months, but nothing more than that. Now, coming to sort of vitamin D, so vitamin D receptor is obviously, as I said, present over 100 genes. It regulates your immune function, it regulates your lung function, regulates your muscle functions, regulates your cardiac function. So obviously, a lot of interest to see how patients with critical illness or will fare if vitamin D levels were sort of corrected. And there's also been association of vitamin D with sepsis, AKI, and respiratory distress syndromes. Some of the things which patients in ITU would be sort of uh, be affected by. Uh, so there was this argument that vitamin D is maybe probably a bystander rather than a marker of illness severity, and people have published a relationship between CRP and vitamin D. So as your CRP goes up, your sort of vitamin D levels fall. Uh, that happens with most of the micronutrients, except for maybe copper. But the levels don't fall very dramatically as it can happen with other things actually. So just a bit about immune function. So vitamin D, again, has genes which affect both your adaptive immunity and sort of innate immunity. And people have looked at something called scathalcidine, which I don't know much knowledge about, but I've seen quite a few publications looking at scathalcidine levels in ITU patients who were given, vitamin D basically. So yeah, vitamin D affects your immune function, and that's why a lot of interest in patients in ITU setting. Vitamin D has direct effect on your sort of T cells as well, actually. So the first thing is a lot of patients in the general population, if you're living in a country like UK, will have pre-existing, vitamin D deficiency. But the interesting thing is patients in ITU, the vitamin D deficiency is much more than you would expect in the general population. And the reason for that being that vitamin D sort of metabolism is dysregulated in ITU patients. So the levels drop quite rapidly once you get into ITU if you are vitamin D deficient. And there are sort of multifactorial reasons for that. And some of them are sort of listed here. So you can get increased renal wasting, you can get increased tissue conversion of 25 hydroxylated vitamin D to 125 and other sort of vitamin D metabolites like 24, 25. It also affects your liver function, so then all your proteins go down. So your vitamin D binding protein sort of goes down, which affects your vitamin D levels as well. So the point is that vitamin D deficiency, vitamin D levels are much lower in ITU patients than in the background population, and a lot of studies have been done to look at that. So these are the studies which have described that vitamin D levels run low in ITU patients, and again here they have used different definitions of what a deficiency is. So some people have used 50 nanomoles per liter, but some have even used 75, which was the older or sort of American cutoff of defining patient as being sort of deficient. So like in one of this study, I think they had deficiency of like 78%. This is the top one over here. So vitamin D levels do run quite low in ITU patients. So one of the first trials which was done, quite a small group of patients. So this was a Belgian sort of ITU person with endocrine interest. So she gave quite low doses of vitamin D, 200 IU and 500 IU, and quite a small group of patients, about 22. And so it didn't make much difference in terms of outcome. But this trial was very interesting in there because she was also looking at bone turnover markers. So these days, we can look at bone turnover markers in our osteoporosis patients to see what sort of bone turnover you're getting. So normally, when your bone is broken down, you release sort of collagen metabolites actually that you can measure in blood. So they were looking at that, and they found these levels go up very high. And even like when I used to do sort of TPN rounds before, we used to come across patients in ITU and even on stroke wards. Sometimes they will just develop hypercalcemia just because they are stationary and bone is going hyperresorption, and the calcium levels would sort of rise actually. So yes, uh, so the idea was that if we can find something which will sort of stop all of this actually. Uh, and then the regular vitamin D, what we call as doses that are given to patients don't really work in ITU settings. So what they found is, so if you were to give your 300,000 IU of vitamin D that we give over 10 weeks, that doesn't do much for ITU patients. You possibly need higher doses. So there have been studies done looking at sorry. So other thing is. So other argument sort of in this debate was that maybe what we are looking at is low levels because of low protein. And should we be looking at free vitamin D? I mean, vitamin D binding protein is not measured outside of research, and there's no way of measuring a sort of free vitamin D either at the moment, actually. Uh, but I mean, there's a trial done, I think, Vidal ICU trial, and they found that whether you looked at free or bioavailable vitamin D or 25 vitamin D, that doesn't really affect your outcome. So people have gone away from trying to, focus their attention on, measuring free vitamin D in trials, and people are just looking at sort of 25 hydroxylated vitamin D in the trials actually. And so before 2017, there were like three meta-analysis done looking at what you call as vitamin D status, and again they found there was increased morbidity and mortality. But these meta-analysis have quite sort of small numbers. And so around that time, the way the discussion was going around vitamin D and its benefit, people said we need to give higher doses than what we give in normal population, and I think they settled around 600,000 IU of vitamin D as a bolus dose to try and achieve good levels. So there are a lot of studies done in which they have given patients around 600,000 IU of vitamin D as a bolus dose, and then they've looked at their vitamin D levels in ITU setting, and they've looked at a lot of markers, surrogate markers of bad outcomes like procalcitonin, cathalcidine, and they've shown that giving high doses do achieve good levels, and certain markers which they have chosen in that particular study do sort of turn around in the right direction. So that sort of paves the way to do sort of more detailed sort of RCTs. So this is one of the RCTs which was done, published in sort of 2014. So this was a mixed ICU group, and what they did was they gave them 540,000 IU of vitamin D enterally, and then they gave every month 90,000 IU sort of top ups. This again did not show any difference in the length of hospital stay, and there was no sort of significant mortality benefit in these patients. What was interesting was that the group which came into the ITU and who was severely deficient, so they've given levels of 12 nanograms per ml. So your 1 nanogram is about 2.5 nanomoles per liter. So this would work out as about 30 nanomoles per liter. So those patients uh, did achieve a significant statistical significance, and the number needed to treat was 6. So the suggestion being that if you enter ITU at a deficient level below 30, maybe there is some benefit rather than giving it to everyone.
So this was a big multi-center trial from US. So this was a double-blind study. So again, here they gave just a single bolus of 540,000 orally or enterally. And the criteria was levels less than 20, which is 50 nanomoles per liter in patients with ARDS. And they were looking at 90-day mortality. Now, this was slightly interesting trial. So this trial was stopped prematurely at in July 2018 itself. And in fact, they were not finding any benefit, but there was a non-significant increase in the treated group. So patients who were actually being given vitamin D, they were actually doing poorly in the trial. So after that trial got published, somebody else went and did a meta-analysis, and they included the most recent trial as well. And then they came back again and sort of saying that vitamin D supplementation decreases need for mechanical ventilation and ICU stays. Further studies are sort of required. Now there's an ongoing trial, so it'll be quite interesting to see what comes out of that. It's called Vidalize. So here, again, they're giving the same dose, which gets patients to get normal levels, about 540,000. And following which, they are supplementing with 4,000 IU of vitamin D every day, actually. So it's quite a high dose of vitamin D. And again, they've selected the group. If you remember the JAMA trial, which I talked about, the levels below 13 nanomoles per liter, and they're looking at 28-day mortality. So this is likely to be completed next year, and then we'll have some data hopefully in 2025 to see what happens. So there was this article. This is a very nice article in Endocrine Connect journal, so this is before your what you call as Violet trial got published. But it makes a good point, saying that some of the ITU admissions are actually elective. And often the patients who start with very low levels are the ones who end up with problems, are the ones where on subgroup analysis, sometimes you do find benefit. So why not just correct it before you have that elective procedure, which needs an ITU admission? So maybe at your sort of, pre-op sort of admission, maybe look at vitamin D levels and sort of correct it as you would do it, gently in a normal population, and maybe that would, give you a better outcome. So yeah, I mean, this is basically the end of the talk, really. So vitamin D, I mean, I think to summarize, vitamin D deficiency is common in patients in ITU. It's more than what you expect in background population. So they tend to, because of dysregulated metabolism, they tend to lose vitamin D. There's a lot of suggestions about vitamin D replacement being useful, but we don't know how to go about it. And again, with the Violet trial, where patients were having poor outcome with just one dose, is something sort of makes you more cautious. There's an ongoing trial, so that it will be interesting to see what happens. I mean, it's been going on for a few years now, so it doesn't look like that the sort of treatment group would have had harm. Otherwise, they may have looked at stopping it prematurely. And again, the suggestion of patients who are coming as elective admissions to optimize their levels before is probably a good suggestion. That's something we should probably can do safely. Uh, so yeah, that's the end of the talk. If people have any queries or questions.
Yeah, we've got one question here.
Hi, it's Sarah, one of the pharmacists. I just want to ask, have you got any advice on when you would recheck a patient's vitamin D after their critical care stay? Thinking of if we were to start a patient on vitamin D supplementation for any reason, when would the effects of critical illness be likely to have kind of tapered down a bit, and when would be an appropriate time to recheck if we were to hand back to GP care?
Yeah, I mean, I think the first of all, I mean, it's difficult how you would correct the vitamin D in these patients, but I
Yeah,
think once they get discharged, you can do a level at that point, and that would be a starting point for GP to sort of supplement that further if sort of required. But I think
yeah,
even like just general advice to say take just 400 units of vitamin D will what do you call us, keep patients away from sort of serious problems. Uh, so usually in the normal population, if you're not in, if you do not have any symptoms suggestive of vitamin D deficiency, we don't routinely check vitamin D unless you are in specific high-risk groups like osteoporosis or some other sort of calcium metabolism patients. In fact, a lot of labs are banning vitamin D test, and it's quite an expensive test. It's cost over 10 to 14 pounds a go, actually. And there's a lot of inappropriate testing for vitamin D. Hopefully, with this newer trials, which is suggesting that there is no benefit of taking very high levels, would probably calm the requesting down.
yeah. Yeah, so thinking about if we were to start a patient in hospital, as you've mentioned, as you've demonstrated in your talk, due to a number of reasons, the critical illness will impact that patient's level. It almost seems like we could be causing a problem to the wider healthcare community, impacting their frequency of need to test, and then going on for regular prescriptions, especially if you've got a patient that socioeconomically isn't in a position to supplement their own, their, buy their supplements themselves. So it's quite a big impact on the wider healthcare community, both from a testing and a prescription perspective, isn't there? So we really do need the results of that trial to know how to direct us.
Yeah. And in fact, there's a document from NHS which suggests that patients with simple deficiency of even things like or like vitamin D, they should buy it themselves, and most GPs will stop prescribing does not sort of entertain prescribing regular vitamin D for like normal population. So only if you're in the high risk group, that's where they would actually check your vitamin D levels or supplement vitamin D levels on prescription.
Thank you.
Thank you for that, Baz.
Sorry, is somebody saying something? Because I could hear some mumble, but didn't really hear anything.
Hi, can you hear us now? You keep freezing at the LRI side.
Yeah, I can hear you.
So just from a dietitian's point of view, so we've been round the houses about whether we should supplement on critical care blanketly or whether we shouldn't. And I think previously we've had discussions about possibly giving 2,000 international units on critical care, but obviously the problems are what Sarah's been describing is when do you stop and whose problem is it? So it seems sensible that if we have got deficiencies, that we look to giving some supplements, because
Yeah, I think if your levels are less than 30, you should try and get the levels probably above 30. That's probably okay. And again, I mean, you may come across patients with levels less than 15 as well, and there you may want to give, up to sort of 4,000 units. But I mean, if their bone profile is completely normal and their sort of, vitamin D is detectable, then maybe just giving sort of 2,000 units a day is probably okay. But I think with this the Violet trial, so in the past I was like quite okay about giving vitamin D supplements to sort of inpatients. But it just makes you wonder because we've been through this route long, like for other things as well. So I mean, at one point thyroid was in vogue, and then testosterone, and then obviously at the moment it's vitamin D, and often yeah, we end up treating numbers rather than having like concrete evidence of benefit in these things. But yeah, I mean levels below 30, Yeah, but it's quite difficult to write a policy around it. I don't know if there's anything nationally around it. I don't think so. There is.
And I suppose the other thing is we can't necessarily check because we've got inflammatory process going on. So we don't always check on critical care because it's not the right time to check.
Yeah. Yeah, so I didn't catch everything you said over there, but yeah. I mean, but I mean, there is argument on both. Yeah, there's argument on both sides. So some people say that it may just be like a bystander because you got inflammation, your levels go down as they do go down for other things. But then obviously in ITU settings, they have shown that metabolism is also deranged. Yeah, I mean, the thing is, case is open, so you almost have to make up your own mind here. There's no concrete evidence to go by, really. But I think like a pragmatic approach would be if levels are less than 30, like a sensible, supplementation of 1,000, 2,000 unit is probably okay because that's so. For example, if somebody is getting PN, they would be getting 400 units of vitamin D or 800 units of vitamin D through that. So that kind of supplementation is probably okay. So even in this trial with the Violet study, they were giving 600,000 at a go. So the problem with that, what happens is you end up making lots of other things. That's unnatural because when we get exposed to sunlight, the maximum they think you make is about 10,000 units. If you get really good amount of sun exposure, so in a day you never make very high doses. So if you give people very high doses, uh, it gets directed into other metabolites which may be causing the harm. So apart from like 125, there's something called as 24, 25. There's something like 26. There are lots of other metabolites which end up forming. And when you're giving this bolus doses, that could be a problem. But yeah, small doses probably may be okay still. But again, as I said, there's no evidence. We don't know what to do here.
Thinking about some of our patient cohorts as well, where you've got hepatic injury, acute renal injury, even giving the supplements, you're not necessarily going to get the vitamin D into its active form. So almost you're giving the vitamin D just for the sake of treating the numbers, but you're not necessarily going to achieve what you want is in terms of therapeutic moiety going around that patient system. So there's also that as well, isn't there? So that's why we need data.
Yeah, exactly. Yeah. So I mean, before these recent publication, there was a lot of what you call as optimism regarding vitamin D, and people were actually giving vitamin D in ITU patients without evidence as well. But obviously, the more recent data suggest caution, and that's been the case throughout. I mean, with lots of things, even with cancers, there was this thing in COVID as well. And in fact, well, certainly giving very high doses is harmful in different settings. So I think what it will turn out is that patients who are running very low levels, yes, they need to be corrected, but then not sort of overdo it basically.
It's quite interesting though that obviously we're supposed to take vitamin D. Most of the population don't seem to know that we're supposed to take vitamin D supplements.
Yeah. So I think that's my key message. So whenever I come across anyone, or I tell them that right now we should all be taking 400 units at least of vitamin D if you're living in the UK. So I think that is a safe takeaway from this talk, I suppose.
Yeah, if the patients are not doing that and then they're on critical care and they're not meeting their basic micronutrients of vitamin D for about a week, it's kind of where we go with supplementation. Should we
So I mean, and I mean, I don't know if some of you like older sort of people may remember. So even with pancreatitis, I do the lipid clinic, and we come across a very rare group of condition called FCS, in which patients get pancreatitis as children actually. And so it was quite in vogue that time to give this antioxidants. So people did lots of trial with vitamin A, D, E, and selenium in pancreatitis group. And in fact, what they found was that the treatment group did worse than the non-treated group. So yeah, I mean, things may look good from preclinical studies and association studies, but when you actually do the intervention, sometimes you get surprised. So yeah.
Thank you very much, Faiz. Thank you for your time.
Thank you.
Hi, I'm Ali. I'm one of the CT3 anaesthetists here, for anyone who hasn't met me. And today I'm going to talk about a recent paper in the New England Journal of Medicine, which was released in October of this year, about inhaled amikacin as a preventative treatment for ventilator-associated pneumonia. And that was a study carried out by all these many people. So why did they do this study? Well, VAP, or ventilator-associated pneumonia, is a big problem in ICU. It's defined as a pneumonia that develops 48 to 72 hours or afterwards following endotracheal intubation. And it's caused by the formation of biofilms above the cuff on the endotracheal tube, and then microaspiration of that bacterial substance past the cuff, which seeds into the lungs and goes on to cause pneumonia, sometimes up to 7 days after the initial event. And despite our best efforts at preventing this with things like oral care, optimal positioning, reducing sedation, and encouraging patients to clear their own secretions, it still remains a big problem. So the incidence, this quote's taken from the paper itself, is somewhere between 2 and 30 episodes per 1,000 days of mechanical ventilation, which equates to around somewhere between 5 and 40% of intubated critically ill patients developing a VAP. And it's a serious illness. The exact mortality and morbidity varies by patient group of the organism that causes the pneumonia, and how early or late the pneumonia develops. So getting exact numbers on how much it increases mortality is difficult. One paper I found was from 1998, which suggests an odds ratio of around 2. So if you get a VAP, it increases your risk, your odds of dying in ITU from your critical illness by approximately a factor of 2. So that's a big problem. So if we could do something to treat that, that would be great. So even better than treating it is preventing it before it happens. So and there have been some studies that have shown that preventative antibiotics may have some benefit for reducing mortality from VAP. And if you're going to give preventative antibiotics, it makes sense to give it by the inhaled route, so as a nebulization, because it allows you to give very high doses to the lungs and treat any bacteria that may have got past your endotracheal cuff, but with minimal amounts of side effects. And I've run several papers already with different antibiotic agents that have shown a range of different benefits with different regimes administered by the inhalation route. So this is a recent meta-analysis of 6 small trials, which showed that it does reduce the occurrence of VAP, but no significant effect on ICU mortality on the basis of this. So the authors of this study wanted to look a bit more and see whether they could provide further evidence with a larger trial. And they thought that amikacin was a good choice because it's likely to balance efficacy with feasibility in terms of its dosing regime. So what is amikacin? It's not a drug that I'd used very often before. So it's an aminoglycoside antibiotic, similar to gentamicin. It's very active against gram-negative bacteria, and especially those bacteria that are typically quite difficult to treat, things like Pseudomonas and Acinetobacter, that tend to be quite resistant to different agents. It does also have some gram-positive cover, mainly against Staphylococcus and nocardia. Its side effects are very similar to other aminoglycoside antibiotics, so things like ototoxicity, nephrotoxicity, and it can potentiate neuromuscular blockade. It's quite a large molecule, so it's not absorbed orally, so it has to be given by the parenteral route, and it's principally excreted by renal filtration unchanged. What I couldn't find is how well it's absorbed from the alveoli into the systemic circulation, which would be relevant for this study. So what do they actually do in this trial? So the trial was called the amikinhale trial, and it was a large multi-centered trial in 19 ICUs in France, so probably quite a similar patient population and demographics to what we have in the UK. and it was double-blinded and randomized. So they selected patients who had been in their ITUs undergoing mechanical ventilation for more than 72 hours, but less than 96. And then they ruled patients out if they already had a ventilator-associated pneumonia, if they had a severe acute kidney injury or chronic kidney disease, if they had a tracheostomy, therefore not an endotracheal tube, or if they were expecting to extubate them within the next 24 hours, as well as excluding patients who are already on systemic antibiotic therapy with a similar drug, aminoglycoside. So they found these patients, they randomized them into 2 different groups, one group receiving nebulized saline and one group receiving nebulized amikacin, a dose of 20 milligrams per kilogram of ideal body weight. And then these patients got a total of 3 doses of whichever nebulizer they're having at 24-hour intervals for 3 days. And if at any point the patients no longer met the inclusion criteria for the study, they were withdrawn at that point, so they wouldn't necessarily receive all 3 doses. They were very strict at maintaining blinding during the trials, so there was a separate team involved in preparing the doses of the medication, and it was all kept with opaque stickers on the nebulizer, so they couldn't work out who was getting which drug, and they weren't allowed to take amikacin level measurements during the trial. Other factors were at the discretion of the physicians looking after the patients, so things like ventilator settings, humidification, muscle relaxant, etc. So there wouldn't have been a major difference between the different groups. So this is very, very difficult to read, but essentially it's just the patient selection. So initially there were 50,605 patients were screened for the trial. 850 underwent randomization after all the exclusion criteria were applied. And then they were split into 2 groups. So 420 had the amikacin and 430 had inhaled placebo. There was a significant dropout rate in both of the groups. So in total, only 337 patients received all 3 doses of the nebulization amikacin. So actually the numbers of patients actually in the trial have fallen quite quickly from their initial screening. Again, this is quite tricky to read, but essentially it's just the patient demographics in the 2 groups. And they concluded that there was sort of even matching, so that the 2 groups were well matched in terms of things like age, sex, and comorbidities, and their cause of admission to ICU. So the primary outcome for the trial was development of a first episode of ventilator-associated pneumonia from randomization to day 28. So they worked out what the average time for a patient to develop a VAP was. And then they had a variety of secondary outcomes, although they do say in the paper that this was exploratory, so the trial wasn't necessarily powered to show significant differences within the secondary outcome groups. So the things they looked at were incidence of VAP, VAP due to gram-negative bacteria, incidence of ventilator-associated events, which are essentially events which were likely to be a VAP, but there wasn't enough evidence to meet the formal definition. So either they didn't have positive cultures or it didn't meet one of the other criteria that they were looking at. They also looked at antibiotic administration, so both in terms of the number of days of administration and what they said was antibiotic days. So if you're receiving more than 1 antibiotic for a number of days, it counts both of those antibiotics. Days of mechanical ventilation, number of days in ICU, mortality, and then any side effects from the nebulization. So this is the sort of headline finding. So this should say, sorry, first episode of VAP. An episode of VAP developed in 62 patients in the amikacin groups, that's 15%, and 95 patients in the placebo groups, 22%. So that's a fairly significant difference, and they've worked out that significance using something called the difference in restricted mean survival time to VAP, which they said is 1.5 days, and that gives them a p-value of 0.04. So highly statistically significant finding. But what does that actually mean? So if we dig down a bit more into that, so I don't know how well you can see the image here, but essentially this is sort of a survival curve. So this inset image is a sort of blown up version of the one on the bottom. So the patients who are receiving placebo, this is how many patients, or how long it took them to develop a VAP. So it plateaus out somewhere between 20 and 25%. And this is the amikacin group, so it's about 2/3 of the total level. So what is a restricted mean survival time? Well, essentially it's a way of quantifying sort of median time of onset of some sort of issue. So you can think of it in this case as the sort of median time from randomization to developing the first episode of ventilator-associated pneumonia. But it's a slightly more robust statistical measurement if certain conditions of your trial can't be met. So particularly something called the proportional hazards assumption, which just means that if you increase the amount of intervention that you're giving, your survival benefit should increase. And the authors of the study felt they couldn't meet that assumption in this case. So this was the appropriate statistic to use. And if you look at the difference between the two groups, then you can calculate whether or not there's a statistically significant change in outcome, depending on what intervention you've given. So in this case, the restricted mean survival time sort of difference was 1.5 days. So there's only 1.5 day difference in your average time to the developing a pneumonia if you receive amikacin compared to placebo. So that doesn't sound like as big a difference as the initial headline with this statistical value seems to suggest. Why might that be? Well, actually, the incidence of development of VAP is fairly low. So in this study, they found somewhere between 16 and 23 patients, a rate of 16 to 23 per 1,000 days of mechanical ventilation. So what effectively we're seeing here is something with a fairly high relative risk reduction, but a fairly low absolute risk reduction. And therefore your numbers needed to treat as the inverse of the absolute risk reduction is quite high. So you need to treat a lot of patients in order to get some benefit from this intervention. And actually you can see that quite clearly. But they've also said the median survival time further down in the paper. So it was 9 days for patients receiving a placebo and 10 days for a patient receiving amikacin. So that's statistically significant, as they've shown, but is it clinically relevant? Is it enough of a difference to actually for us to change our practice and what we do? So we'll come back to that at the end. In terms of secondary outcome, they found a similar effect in VAP specifically due to gram-negative bacteria that would be susceptible to amikacin. So with a slightly larger effect than seen in the primary outcome group. But again, the RMSD difference was only 1.9 days. So there's a similarly small effect in real terms. Oh, sorry. This is probably too small to read, but this just shows the same survival curves in terms of ventilator-associated complications, infection-related ventilator-associated complications, and possible ventilator-associated pneumonia, which are these three different respiratory complication groups that they looked at that didn't meet the formal definition. And again, it shows a similar effect. Interestingly, they've chosen to put down the hazard ratio here, which is a different statistic from what they used for the primary outcome. I'm not quite sure why they've chosen to be inconsistent with what statistics they're using. But it probably doesn't show anything significantly different to the main group. In terms of antibiotic days, so the rate of antibiotic use was 887 per 1,000 days in the amikacin group and 968 per 1,000 days in the placebo group, which is a rate ratio of 0.92. But actually, the confidence interval for this goes through 1, so it's not statistically significant on the basis of this study. But as I say, this is probably underpowered to show significant difference for the secondary outcomes. They also looked at time spent undergoing invasive and non-invasive ventilation, and essentially it was exactly the same between the two groups. So on average, they spent 9 days on invasive ventilation, 2 days on non-invasive ventilation in both the amikacin and the placebo group. So there was no difference at all. So mortality, so 99 patients in the amikacin group and 112 in the placebo group died in ICU. So it's a hazard ratio of 0.89, and again the confidence interval goes through 1, so there's no statistical difference in mortality whether you receive amikacin or placebo. Adverse reactions were very similar between the two groups and quite low, and the effects that they did see were due to the nebulization itself, so things like blocking filters rather than side effects from the drugs. And notably, the reported rate of acute kidney injury was lower in the amikacin group compared to placebo, so it doesn't seem that you're getting significant toxicity from the drug itself. So what was good about this study? So it's a large multi-centered RCT with rigorous methodology, good attention to blinding and matching between the different groups, and it did show a strong statistical difference between rates of VAP between nebulized amikacin and sodium chloride. However, that effect is very small, so the difference in your average time to developing VAP is only a day and a half, regardless of whether you receive the antibiotic treatment or not. And they didn't manage to show any difference in mortality or ventilator days by prophylactic treatment with amikacin, although, as I said, the study wasn't necessarily powered to detect that. Why don't we see a mortality difference if there is a reduction in VAP? Well, as we say, first of all, the actual difference in real terms is fairly small, but other possible possibilities. First of all, the rate of systemic antibiotic administration is very, very high in both groups. 78% of people in the amikacin group and 77% in the placebo group are already receiving systemic antibiotics, which is going to dampen down any effect that you see. And there's been evidence in previous trials, so in this inhaled trial in 2019, that there's no advantage to giving systemic amikacin or any other antibiotic over intravenous therapy with antimicrobials. The other possibility of why we're not seeing more of a benefit is the timing or choice of dose of administration. So in this study, they gave only 3 doses of amikacin at 24-hour intervals, and actually most of the VAPs are developing on average 9 to 10 days after randomization. The half-life of amikacin in the body is actually quite short, although it's not entirely clear how quickly it's being uptaken from the lungs. And if we remember from the start, pneumonia might take 7 days to develop between the actual aspiration event and it becoming clinically apparent. So it's possible we're just not continuing the dosing of the amikacin for long enough in order for a more substantial effect to be seen that would change mortality. And lastly, I just wanted to point out that this is their sort of conclusion from the study. So they said among patients who received invasive mechanical ventilation for at least 3 days, a subsequent 3-day course of preventative inhaled amikacin reduced the burden of ventilator-associated pneumonia during 28 days of follow-up. And that's factually true, but it actually misses out quite a lot of the more subtle detail in the study. And a lot of the way that they've used the statistics throughout the paper doesn't make it particularly clear that the actual magnitude of the effect is relatively small. The way they've chosen to present their data seems to sell the fact that this is a positive trial, but without actually considering what the clinical effect is. So just something to think about when reading papers like this in the future. So should we change our practice on the basis of this study? I think probably not on balance at the moment. There wasn't evidence that it did harm, but on the other hand, there's insufficient evidence that it actually made any difference. It certainly didn't affect outcomes in terms of mortality or ventilator days. And the actual magnitude of benefit in terms of reducing rates of VAP was quite small, as I've said before. It does mean the fact that they haven't shown any particular harms from nebulization means that we can go on to use larger studies to see whether there is any benefit. And so perhaps on the basis of those, we might change our practice in the future. Thank you for listening, those of you who did. Any questions?
I believe it's just the study is quite sufficient sample, 5,000 patients. 19 ICU.
Yeah, well, so they've screened 50,000 patients in ITU, but actually the number of patients included in the study was quite small.
I think if they did some change in the methodology, so excluded the systemic antibiotic patients and measured the amikacin level, because I'm not quite sure. I don't know if Sarah has an idea. Yeah, we give amikacin once a day if it's IV. I'm not sure of this relation, if once a day is going to achieve the same shapes and different.
Yeah.
Depends what you're aiming for, doesn't it?
There didn't seem to be really any particular reason why they've gone for 20 milligrams per kilogram for this dose. They just sort of picked a number out of thin air that they thought might be
and why
a good level.
3 days also. So I think with some change in the methodology, we make it quite the results that we need to look at are the results that can change our practice. So it's really going to change it.
I also wonder about the long-term antimicrobial resistance impact as well.
Yeah.
And is it a trade-off? You know, if you had a bigger group that you were prophylacting, you might save lives in the short term, but then actually introduce resistance. And ITU is already an area that we kind of tend to see those nasty bugs selected out. So I wonder how that would change in time.
Yeah.
With the
Absolutely. You should have looked at the resistance of the bugs for the third patients with amikacin and compare it to a secondary study.
That would be interesting.
Affiliate you with any prophylactic. Just
you're just going to select out all the nasty things.
And it's one of the drugs that we kind of really use as the last line for those horrible, nasty pseudomonas infections that we're so clever at, going to their biofilms and infiltrating every little cavity on the unit. It's interesting. Kind of reminds me a bit of that Sudoku and the selective decontamination of the gut in ITU, that kind of study. So it's almost like we've explored the gut and decided that that's not an appropriate kind of area to prophylact. Let's now kind of explore the lungs as well. If you, as an individual and as a relative, you would want any prospective future harm to be avoided, wouldn't you? And maybe your priority wouldn't necessarily be the kind of wider picture at the time. So you can see how someone will get a paper like this and then try to encourage it. I think we had a patient once that we were being told to you know, if we're being encouraged to use something that they'd found on the internet, that, you know, can you give this as a reflect, and it does put that kind of situation into light, isn't it? You know, actually, when you've got something that might impact one patient positively, but then looking at that bigger picture from a community perspective, you've got to consider that as well.
And actually, now think about it, for the same patient as well, because they've only looked at first episode of VAP here.
Yeah.
For some patients who are here for a very long period of time, they might get a second, third, fourth episode, and maybe you're just selecting all the worst things, and they'll just get hit harder on the second time.
And as a relative, you wouldn't necessarily have that information or the emotional capacity to understand the impact of that at the time. You'd want anything done to save your loved one.